Good morning, everyone. This is session IC09, Made for Each Other, Kids Custom Seating and 24/7 Posture Care Management. My name is Madeline. I will be moderating today's session and will provide the CEU code at the end. Before we get started, please remember to mute yourself and questions can be asked using the chat feature. I will go ahead and turn it over to Tamara Kittleson, your presenter for this session.
Hello, everybody. I hope that you're having a good morning as we're just starting off with this first ISS, totally virtual. I'm Tamara, talking to you today from the Central Time Zone. I'm not sure what time zones you are all in. I live in Missoula, Montana. I'm in Minneapolis, St. Paul, visiting family and being able to share this time with all of you. Seem to be having a little bit of trouble. There we go. There's my slide going. I want to begin, as I begin all of my presentations, introducing you to my youngest daughter, Eleanor. Eleanor has been gone now from this earthly plane for more than 20 years, but I introduced her because she taught me so many things that one never learns in OT school or PT school or any kind of school, actually. So I'm just always eager to be able to share the fact that I've learned a lot from her as her mother that I never learned as a professional. Let me just get things set up here. Okay. So we've got our learning objectives, which I trust all of you have looked at. You don't really need me to read these to you. You can read them as well as I'm able to read them to you. And I do want to briefly tell you about HAMI. You're going to be seeing HAMI, the simplified anatomical model, in some pictures today. I was going to try and do live demonstrations. I felt that that would be just a little bit too complicated being online. So briefly, this is HAMI sitting on his place of birth, which is a 3D printer, and introducing HAMI as a means for sharing about postural concepts. We can demonstrate what goes on with a person when they have tight hamstrings, when they have tight hip flexors, the effects of multi-joint muscles around the pelvis, and how pelvic posture ripples up the spine, affects the torso and head, and also actually ripples down and affects the legs as well. It's a little easier to see some of these concepts on HAMI than it is on a traditional skeleton, so you will be seeing some images of HAMI today. Should you be interested in learning more about HAMI, you can go to meethami.com and you can learn and read all about him. So for starters, what we're talking about today is working with kids and young people in seating. And what are some of the issues? Well, what do we know about kids? We know that they grow and they develop and change. That's just a given. And even if their developmental milestones are not happening at the typical time that we might be looking for average kids, they are still going to change and grow and develop over time. What do we know about aging with a disability? And that is change continues all the way through childhood and into adulthood, and secondary complications tend to happen. Now, as a person who is in an aging state of life and very healthy and able, I can relate to the fact that change continues. And so I think that we as clinicians and providers need to be very aware about aging with a disability from the very beginning by tying these together for optimal outcomes. So we can develop new ways of seeing what's going on with people, not only thinking about what's going on right now, but what is going to be going on in the future so that we can take action early. Now, kids have places to go and things to do, and it can be all sorts of variety of things, regardless of how independent they are. All kids are enmeshed in their natural environment, and we need to be making it as possible for them to be able to fully engage. So let's talk about the terms in my title today: custom seating, 24/7 posture care management, and earlier intervention. When I'm talking about custom seating, I'm talking about something that's fabricated to fit a specific individual. It's non-planar, so it's not something that you can just grow by moving the backrest back and the seat is still going to be staying the same. It's not off the shelf. And sadly, too often, custom seating, custom molded seating is not considered and provided for kids because of a whole host of concerns that I understand very well and that I experienced myself when I first began doing this. 24/7 posture care management. This is a topic that is near and dear to my heart. I've been spending the largest part of my professional life for 10 years now, trying to raise awareness and here in the United States and provide training on this topic. Basically, with 24/7 posture care management, we are looking at somebody all throughout their day, all throughout their night. We're not only concerned about their wheelchair seating, their standing frame, if they are lucky enough to have that, but we are also looking at the time that they're spending outside of those specialized pieces of equipment. So we're looking at how they're sleeping at night. Do they have nighttime support? We're looking at what happens when they come home from school and they lounge around on the couch or the recliner. We're really paying attention to all of these different things when we're talking about 24/7 posture care management. And early intervention. As somebody who spent many, many years as an early interventionist, I did an advanced master's degree in pediatric rehabilitation back in the day in the 80s. This is a topic that's also very near and dear to my heart. And you can see what the Early Intervention UK Foundation has to say about early intervention, identifying and providing effective early support to children and young people who are at risk of poor outcomes. And we often think about that just in terms of developmental outcomes. But I'm proposing that we think about early intervention in terms of the assistive technology that would provide, specifically seating and mobility. So this early intervention, as our own CDC says, can change a child's developmental path and improve outcomes. So it's really imperative for when we're working with children and youth for us to be thinking about these things. Now, what are some examples of early intervention that is already happening and is pretty well accepted in our field? Self-initiated mobility equipment. There's been a huge push, and I've been an encourager of this as well, for self-initiated mobility equipment, early power chair use. We've now got a wonderful device developed by Permobile that is specifically designed for early self-initiated mobility. Some of the early scooter boards that kids could operate with switches to get a sense of what it was like to move through space when they couldn't do it on their own. Supported standing devices are another one. It's becoming increasingly well accepted to start standing programs for kids who are really, really young. And we now have the devices that are built to be small enough so that it's actually practical enough to do that. Early use of sign language and alternative and augmentative communication. So these are all really great examples of early intervention for AT. But I would ask the question, what about early and targeted postural support? I think that this is something that is often delayed and not jumped on as early as it could be. And the question would be, why do we wait? So early intervention in seating requires a bunch of stuff. It requires understanding not only what is happening, but what will happen to the body, giving careful attention to all positions in and out of the wheelchair, analyzing lying and sitting postures, and realizing how closely they are linked. We're going to be looking at that closely today, and using a team approach that includes families. So why do I care about this? I worked with kids in seating and positioning for many years. I've lived in the same community for 38 years and still have clients today who are in their 30s that I got to know when they were infants or preschoolers. And here I am still all of these years later, helping them with their equipment. And that has given me the opportunity, sadly, for some of them, many of them, to watch their bodies deteriorate, although we've tried to do the best we could with daytime mobility and positioning equipment. And over the years, some of those people have died because of secondary complications, severe scoliosis that compromise their breathing and their cardiopulmonary function, basically. Some of them complications from surgeries. And so for a long time, I really regarded custom molded seating as a last ditch effort, that you do this once somebody's body has become so distorted that there's really nothing else you can do. Nothing off the shelf is going to fit for them. And so you try and contain the damage that has already happened. But my perspective really shifted over a number of years. I learned about a more orthotic prosthetic approach to seating, where we can have a close fit with intimate contact to have an orthotic effect as a person is sitting in their wheelchair. I discovered the power of 24-hour posture care management, which was huge for me. And I realized that applying early intervention principles could lead to better long-term outcomes, not waiting to intervene with 24/7 posture care management, not waiting to intervene with more aggressive seating approaches, but really looking at what is going on with the person now, and then being able to analyze that to be able to see where that it's going to go, and not waiting until it gets really bad. And as I began to change in this way, I actually experienced success using custom seating for children as young as 1 year old. So what do we know about aging with disability? Now, we know that secondary health conditions tend to arise for all of us, whether we are able-bodied or not, and they are influenced more strongly by the presence of physical impairment. So over time, people with physical impairments who are experiencing the aging process are going to tend to experience more postural deviations, and we're going to be talking about that. Postural deviations over time are going to impact a whole host of things: their motor control, their skin integrity, cardiopulmonary function, oral motor control and swallowing, their visual field, communication, and overall quality of life. So when we look at somebody with a little postural deviation at a young age, it's real easy to think, well, they're flexible and this isn't going to be that bad. And, we're just going to hope that their development is going to improve to the point that this won't be a problem anymore. And I'm here to try and share that those little postural deviations that we see at young ages are red flags that we should be paying attention to. Now, an early childhood diagnosis may not be progressive in the sense of the condition progressing itself, but those secondary complications are still going to be likely to happen just through the aging process, through gravity, through time, through the asymmetrical postures that people assume. We really begin aging the day we are born. So let's talk about postural tendencies. There are 3 human postural orientations. What I call the first and foundational is the lying orientation, because that is the first thing that we can do when we're born. When we are born, the only thing that we can do is lie around unless a parent or loving caregiver is picking us up and supporting us in an upright position. So this is a really first and foundational, pivotal orientation for us. And learning some ability to control our lying posture is a really important building block for the preceding other human postural orientations. So there is such a thing as a quality in lying. We can all look at how a person, for example, with severe cerebral palsy is able to lie on a bed or a mat compared to a person who has full control of their body. And we can see some differences. And what we need to recognize is that ability to lie in balance and have a midline oriented pretty symmetrical lying posture is going to be a building block for the next human postural orientation, which is sitting. Now, obviously, here we are at the International Seating Symposium. We're super interested in sitting posture, and we're really interested in helping people be healthy and functional. And then finally, the third human postural orientation is standing. And that's not our big focus today, but these are the three human postural orientations. And in my experience, here in North America, we spend a lot of time on the sitting piece and the standing piece, and we don't spend a whole lot of time on the lying piece, even though it really is first and foundational. So let's just take a look at a posture here in sitting, a way that we can analyze posture. This happens to be my little girl, Eleanor, when she was a little bit less than 5 years old, sitting in a real unsupportive chair because we were on a camping trip. She could sit much better than this in her wheelchair. But I want you to look at what's going on, of course, with her pelvis oblique, her shoulders. You can see her wide base. You can see she's working real hard to stay sitting up, right? These are all things that are really important red flags that we need to be looking at from a really young age. And now let's take a look at lying posture. This is a guy that I worked with for many years. I think he was 16 or 17 at this point, Dominic. And I asked him to just lie down on the mat table in a way that he would normally sleep or rest, what would be comfortable for him. And this is what he did. And if you look at the lines I've given you there, you can see how far off from midline orientation he's deviating. You can see what's going on with his shoulder girdle. You can see what's going on with his pelvis. And I can just tell you right up front here, the reason he's doing this is because he has tight hips and knees. He has tight hamstrings. And so in his lying posture, his legs have to go someplace. And in this case, they're going windswept. We'll talk a little bit more about that later. So posture deviations and disability. If a person has deviated posture, is it really a choice? Are they choosing to lie that way? Was Eleanor choosing to sit that way? Was Dominic choosing really to lie that way, even though that he thought he was? And if it's not a full choice, what is really happening? Well, we all have postural tendencies, and people who cannot move easily in and out of them into a lot of varied positions are going to develop posture deviations that eventually can become obligatory. And there are lots of factors. So we all tend to think right away of muscle tone and reflexes and weakness. And there's a certain amount of adaptive asymmetry for activities. Just look at all of us who are right hand dominant or left hand dominant for different things that we do. Sensory impairments and processing can play a big role. Inadequate positioning and the environment. There's just all kinds of factors. But what remains is that people who are not able to move easily and with a lot of variety are really left as victims and vulnerable to developing body shape distortions. So this is why I say take early postural tendencies seriously, because they will not go away. This is a little girl that I actually helped her get a new power chair just in the last 6 months. She is now a beautiful junior in high school, quite a gifted young person. She's a writer and a poet and an activist. She's going to make a difference in the world. But in the first image, you can see that she was about 2 years old, two and a half. And you can see the beginnings of that windswept posture. And like a lot of people would, I thought, I was able to correct her. She was flexible. I figured that this was going to be okay. And by the time she was 9 years old, in the second image, you can see the great big lift on her shoe. And that is because by then her left hip had been totally reconstructed because it had become dislocated. I did not recognize this red flag in the first image. And while she's absolutely a wonderful person, she's been left with a lifelong difficulty that might not have had to happen if she hadn't had to have the hip reconstruction that left her with a really significant upper leg length discrepancy. So let's take a look at supine lying postural tendency to really see what I mean. This is a little girl that I worked with in Peru in 2017. I had the opportunity to sit and watch her as she was resting while her wheelchair was being worked on. And I took a whole series of pictures because I was really interested to see what she was going to do. So these are all images that I took of her as she was sleeping on the mat. Now this one that I've got, the most recent one right there, I thought maybe she was going to turn the other direction, but she didn't. So what do you see in all of these images? You can see that while she is moving, she is not really moving with a great deal of variety. And so when parents or caregivers say to me that their child or their person moves in bed a lot at night, my next question is always, but how do they move? Do they tend to always lie in the same place or land in the same place as they're moving? Has their orientation ever really honestly completely changed? Or is it always a little bit stereotyped, as you can see in these images of this little girl? And here you can see the connection. So there she is, quite honestly crying because she was really tired. It had been a really long day waiting for her wheelchair. This was on a work trip in Peru with my nonprofit organization, Eleanor's Project. And it was her first wheelchair at age 3. But I want you to take a look at her lying posture and then look at her sitting posture. And I hope that you're able to see some really subtle connections here between the way that she's lying, her habitual lying postural tendency, which was basically all she had until she got this wheelchair, because she was not able to sit up. Unless parents were holding her to sit up and feed her, she spent her entire life lying down. And at age 3, you can always see, particularly if you look at her leg posture, you can see how that habitual lying posture is feeding into her sitting posture. Fortunately, she is now receiving intervention. Her parents were taught how to do therapeutic positioning with her when she's sleeping at night. And so we can hope that things have gotten better since then. So wheelchair seating and postural tendencies, there's a huge interaction. All of our function involves both activity and rest. So any postural supports that we're using are going to have to allow for rest and fine motor activity and gross motor activity. And for most of the people we work with, they have one piece of equipment that is expected to suffice for them for all of these many and varied things. So a resting posture is for everyone part of the time. It's for you and me. It's for able-bodied and people with impairments. It's going to give us a break from activity. We can't always be on. We need to be able to take a break. We need to be able to have some relief from gravity. And for some people, a resting posture will actually be the most functional because of weakness, because of cardiopulmonary demands, because of whatever it might be. So this resting posture you can see is demonstrated for you in this little picture of Opal. She's the girl who's in high school now. Now, fine motor posture really requires proximal stability, the ability to come out of the resting posture. We want to promote symmetry and midline orientation and some adaptive asymmetry, as you see with this little girl, is always going to be normal, but you need to have a stable base to move off from. So this was a little girl that I worked with in Peru. She was probably 3.5, 4, and arrived in a badly outgrown baby stroller because it was all she had. Could not really do very much with her hands at all. But once we got her into a wheelchair with a seating system, her pelvis was stable, her trunk was stable, you can see that she was able to differentiate and was able to actually interact with a fine motor activity. And finally, gross motor posture. This is going to be athletics, active mobility, people who are able to self-propel. Adaptive asymmetry is always going to be normal for these folks, but it may result in postural deviation. So person may be propelling away to get themselves to class or to get themselves to wherever they need to be. And then when they get to where they are, they may need to do a little bit of repositioning to make sure that they're back into their most symmetrical and midline orientation for fine motor activities or for resting posture. So thanks to my friend Tom Hetzel, any of you who've ever been to the Ride Design Seating course will recognize some of these images. These are really good ones for really graphically illustrating for us seated postural tendencies. So here we've got our anterior tendency, really anterior pelvis. We've got a more pronounced lordotic curve in the lower back. And here you've got an image of a real kid who is very, very anterior oriented to the point that he spent most of his time on his legs. Here we have the lateral rotational tendency. And it's quite a graphic image, I realize, of the boy that I met in the Middle East a number of years ago. But here you see both the pelvic obliquity, you can see the elongated side, the shortened side, but also the rotation that is happening. And we'll be coming back to this boy a little bit later. And finally, the posterior tendency, the best for rest, okay? Not that we want to have a person sitting in sacral sitting on their tailbone. Obviously, we need to have postural concerns. But if you want to think about what is going to give a person the best opportunity to be able to have gravity on their side when they're not actively doing fine motor activities and they're not actively propelling themselves or doing other gross motor activities, you really need to have at least a little bit of posterior tendency. And sometimes all we're talking about is just a matter of a few degrees. So so that you're having a little bit of gravitational help. So what are some of the biomechanics of postural deviations? I've already talked a little bit about gravity and time and asymmetry and what it does to people. I have this picture up here because I use this to demonstrate the prevailing forces. So what we're talking about here are the prevailing forces of gravity and asymmetry over time. In this image, we're talking about the prevailing forces of winds in a high alpine area in Montana, and you can see how the trees have been distorted and they tend to grow in a similar direction no matter which tree it is. So here we're going to be talking about gravity and asymmetry over time. Now, the seminal paper about this was published in 1976. That was only a year after I graduated from OT school with a bachelor's degree. They described severe deformities, as they called them. I don't use that term, but they described severe deformities of children with cerebral palsy. Now, at the time, these were thought to be unavoidable, and that it was just part of the diagnosis of cerebral palsy. But they came up with a hypothesis that it was resulting from habitual postures and the effects of gravity over time. They called this postural or positional molding. This paper has been followed up extensively and put into action in some other parts of the world, particularly in the UK, not so much in the United States. If you have a chance to read this paper, I'd highly recommend it. It's very interesting. They use some terms that will be unusual to you, but it's worthwhile. And if you can't get your hands on it, contact me and I can share a PDF with you. So an example of this postural or positional molding is positional plagiocephaly. Of course, we've seen a whole lot more of this in the years since the 1990s when babies in North America began always sleeping on their backs. Babies spend a lot of time in car seats, a lot of time in strollers, and the natural action of gravity on the baby's soft skull can result in a situation like what you see here. But Kawakami et al. In 2013 actually published a paper on asymmetrical skull deformity in children with cerebral palsy. And they were looking at the frequency and correlation with other body shape distortions. And this is what we're seeing now. These things do not just exist on their own. It's like a syndrome. It's all of a piece. So when you start seeing distortions in one place, you can see that they're going to be happening in other places. Now, this is my puppy, and he is illustrating for us that with frequent position changes, the body bounces back to original shape. He can scratch, he can stretch, he can do whatever, and he goes back to the shape he was in to begin with. But with limited movement, eventually the body does not bounce back. This fellow on the orange mat, Ken, is somebody that I knew for many years. He grew up in a institution in Montana. And you can see that whereas the little able-bodied baby on the blue mat on the left is doing her little typical asymmetrical tonic neck reflex posture, I can tell you that pretty quickly she moved right out of that and into something different. If a person is tending to be stuck, though, because of reflexes, because of anything, because of whatever, so that they can't easily move in and out of it, over time, they're going to tend to be more and more stuck, as Ken eventually became. So gravity always wins and eventually leads to obligatory postures if we don't do something about it. So a limited movement repertoire equals limited postures over time. We saw that in our little girl in the pink outfit. Soft tissue adapts, ligaments stretch, and joints are going to sublux and dislocate, given enough time. Over time, the body shape changes as gravity impacts the body, and all these things are happening so that the posture becomes obligatory, and the supine and prone postures mirror each other. And we end up seeing a similar posture, whether people are in lying or in sitting or in standing. I see here's a pretty graphic example of what I'm talking about. You already met Abdullah a few slides back. This was his position for about 17 years of his life. He was 17 years old when I met him, and he had spent most of his time lying in the posture that you see on the left. There was really no option for him. And when you sat him up in a supported sitting position, you can see his mother's finger pointing to her concern about his pelvis and his rib cage being in proximity. You can really clearly see the elongation on one side, the shortening on the other side, the prominence of his back, and how over time gravity has just really flattened him onto the surface. Again, here you can see all the different orientations. Another former client of mine, if you look at his trunk curve, his spinal curve, you can see it when he's lying. You can see it when he's quadruped. You can see it when he's sitting on the mat, and you can see it in the standing frame before we got the trunk pads on. So it's all linked together, and you see it everywhere. I mentioned mirror image postures. This is a great example with Ken. In the first image, he is as prone as he could be. The second image, he is as supine as he could be. But you can see that whether he's prone or supine, his body is basically still the same shape. And this results in needing really complex seating. Intervention too late. Here we are doing exactly what I always thought custom molded seating was for, which was to contain the damage and try and seat somebody who really cannot sit any other way. That's exactly the situation it is, as it was for Ken, and that it is for so many people today.
So let's talk for a minute about young hips. Infant hips are more cartilage than bone, and hips develop fully by the age of 2 years. So if we're seating kids who are not 2 years old yet, we can perhaps actually have an impact on how their hips are developing, in addition to hopefully what they're getting from being in a standing frame, if that's what they need to be having. So the hip joint basically becomes deeper and more secure through positioning. Yeah, you can see this typical abducted and flexed leg posture of this baby. This is very, very typical. And through weight bearing. So positioning and weight bearing are the things that we have to be able to help with kids' hip development. So if flexed and abducted postures are typical in development, can we incorporate this into seating for young kids? So maybe we need to be really looking at what we're doing for their seat cushions and changing the alignment a little bit so that we're really encouraging that flexed and abducted posture that a lot of kids are experiencing all the time voluntarily. And then, of course, supported standing by 12 months, ideally in abduction. And a lot of people are writing about that now. So did you ever wonder about pelvic posture deviations, such as where that pelvic obliquity came from and where that rotation began? So I have come to believe that it might very well have started at night before you noticed it in sitting, because we may be seating somebody, maybe somebody we've known for quite a while, maybe somebody we're seeing on a regular basis. This happened to me. This is why I can speak to it. And then suddenly, you see someone and you haven't seen them for 3 months, 6 months, maybe longer. And oh my goodness, where did that pelvic obliquity and rotation come from? They weren't like that last time we were together. This seating doesn't work for them anymore. I really believe now that it may have been brewing and developing at night, and it's just now starting to become evident in the daytime in the wheelchair seating. So leg posture and lying is really a domino effect. As I mentioned earlier with Dominic, tight knees and hips limit leg extension. And so if you're lying on your back, or if you're placed in lying on your back, and if your legs cannot straighten and have support underneath them, they are going to fall and they're going to look for support. So they may fall with knees together if you've got pretty tight hip adductors. They may fall with your knees out to the side, especially if you have low tone. And for a lot of people, they fall with both knees to one side or the other, and we call that windswept. So this is obviously going to have a big impact on wheelchair seating. And here's Hammy just demonstrating for us these postures. And we need to keep in mind that these positions are putting hips at risk of dislocation, of becoming less stable than perhaps they need to be. And here's some real live images of kids that I've worked with. And you can even see Hammy right in the middle as we were teaching his parents about what was really going on with their son's posture when he was lying. So chest and spine 101, let's move up the body to the chest and spine. Want to make a point of the flexibility of the rib cage and chest. We can think of our ribs as being pretty rigid, and they are. You can break a rib, but there's also a sizable portion of our rib cage and chest that is made of more cartilaginous sort of material, as I'm pointing out here. So we've got the xiphoid process down at the bottom of the sternum, which is obviously a bony part of our body. But then we've got this softer, a little bit more flexible sort of substance that is connecting our hard ribs to the sternum. And that's the chondrocostal bridge, which is a more sort of cartilaginous kind of substance. And it is what helps give us the beautiful flexibility that we have. So I'm just going to show this to you now briefly. I think this is really a gorgeous image of how our rib cage is working for us all the time. But I want you also to imagine what happens if you have a body shape like Abdullah or like Ken, and the difference that's going to make in the function of your rib cage and your ability to breathe. The risk that people are put at for restrictive lung disease as they develop severe scoliosis. That's been a major complication that I've known people to die from who had severe scoliosis. So moving on. So what can go wrong, with our upper body if we don't quite have our pelvic foundation straightened out? Well, we may have lateral bending to the side, which Hammy is demonstrating for you here. We may have rounding, kyphosis. We can have flattening of the chest, compression, twisting, and of course, as we saw with Abdullah, pelvis and rib cage proximity. So here's a pretty graphic image of lateral bending, rotation, and rib pelvis proximity and what's going on inside, where we can actually see the compression that's going on, particularly for the left lung, how some of the contents of the abdomen, the abdominal contents are being pushed up into the rib cage in places where they really don't belong. This was prior to this client having a spinal fusion surgery, which was successful, and he did well. And what am I talking about when I say chest flattening? I think many of us who've been working for a while have seen this. You often see it in people who are stomach sleepers. In these cross sections, you can see the sternum and you can see the spinal column. And I've put in a blue line in there to show you the imaginary sternal spinal line. This is a term that is used in the literature, but it's not a real anatomical landmark, but it's the imaginary line that goes between the sternum and the spinal column. And in the best of all worlds, it ought to be vertical as you see it here. Now, in the first image, you've got a pretty rounded, typically shaped chest cavity, rib cage. In the one below, you've got one that is more flattened. And so you can see that you don't have as much space there for cardiopulmonary function. You can see the shortening of the sternal-spinal line. Now, things get really complicated when rotation enters the picture. And this is exactly what happens once people begin to have both of their legs falling to one side. That's twisting the pelvis, but also twisting the rib cage as well. So in this image, you can see that, and I've got a little image of the rotoscoliosis up above, so you can see kind of the outside image of what this might look like. You can see that as the person has tended to rotate, roll a little bit more to their left side over time, I'm sorry, the right side in this image, you can see that that sternal-spinal line is no longer vertical. So you've got the sternum migrating more to the left. The sternal-spinal line is diagonal. And the blue arrows on top are demonstrating the action of gravity. So you've got gravity coming down on something that is already diagonal and is going to be tending to be pushed even more into the diagonal than it already is. So you see here how we can find the development of the rib prominences that we notice, the tendency of one side of the chest to be more flat, the other to be more rounded as the scoliosis develops. Here's just a little sort of a graphic image to show you an example of chest rotation and scoliosis when I'm talking about rotation. Okay, this boy had 45-degree scoliosis. I have put that little blue dot there for you to see where his xiphoid process is. And if you look closely, you can visually, without even having any measurements, you can see that one side is shorter to the outside of his rib cage than on the other. And this is exactly the kind of chest rotation that I'm talking about. A colleague in Australia, Baz Jansen, calls this the canary in the mine, that you may be able to see this before you're seeing anything else other than on x-rays. So gravity is powerful and it will win. Small imbalances and asymmetries are going to progress with time. The human body is always going to follow the path of least resistance. And so we need to give some people some help if they are not able to resist gravity well. Unsupported body parts are influenced by gravity, as we've already talked about, with the legs being pulled down until they finally find support. Over time, soft tissue adapts. All those of us who are therapists learned that in therapy school. And the body becomes distorted and less functional over time. So what we want to try and aim for is a level pelvis, a balanced sternal-spinal line. And if we can try and keep the body stable and balanced, then gravity can be harnessed for good. And we want to try and do this for young kids. But I will add also, I did add a parentheses at the beginning on my introduction slide or my title slide. I did say for all ages, because I'm really promoting early intervention for kids, but I'm also really promoting early intervention for people with new diagnoses, for people with new spinal cord injuries, with new traumatic brain injuries, with new whatever it might be that they have. Don't wait until the body shape declines before you actually start doing something about it. I know that we worry about funding here in the United States anyway, maybe other places. But I think there's a real tendency for us to be sometimes more optimistic than we should be, that if we just wait, things will work themselves out. And that if we just wait, the person will get stronger or reach that developmental milestone or whatever it might be. Now, I'm not saying don't aim for those goals. I would never say that. But I am saying that we should not just let people be languishing in habitual asymmetrical postures while we're working for those strengthening and developmental goals. So we want to start with a mat assessment, of course, and we want to look for symmetry and midline orientation. I talk about those things a lot, both in sitting and in lying. Now, we often have people lying on the mat table. What I see, though, is that we'll be looking at things that are related to our seating goals, but we don't always just look at those postures and come up with lying goals as well. And that's what I'm promoting. So the majority of kids are going to begin life with symmetrical body shapes and flexibility. For many, this is not going to last. And so we really need to take action early while we can. I'm now going to share with you a little case study. His name is Xavier. He is a teenager now, and I haven't seen him for quite a while because he moved to a city about 6 hours away from me. But Xavier was born with spina bifida, an L4-5 lesion. He had a pretty strong anterior pelvic tendency, which we've already talked about. Now, you know, the lesion in spina bifida often destabilizes the pelvis, and it's often asymmetrical due to development in utero. Xavier was fairly lucky, though. He had bilateral dislocated hips, but he actually sits with a level pelvis. So that was a really good thing in his favor. He's a full-time wheelchair rider since the age of 2. He had really excellent wheelchair skills, and he was super, super active, super independent, never slowed down. So that anything that we were going to do with him had to be sure that it was not going to impact his function and his being a really active kid. So here he is, and you can see that I've titled this the Sitting Posture Red Flag. And I hope you can all see the red flag that I saw. I've put a line in there to make it easier for you to see it. I hope that you can see the deviation of his upper body over toward his right side, our left, as we're looking at him. And to make it even easier, you can see the head support behind him. He didn't really need it, but the school required it for the school bus. You can see that as a really good marker showing you that he is off center. His midline orientation is shifting. So this was a red flag to me. Now, until this point in time, he had had fairly low profile seating. He had a low wheelchair back that allowed him a lot of freedom for propelling. He sat with a level pelvis. And so we just, went with a fairly low profile cushion. But when I saw this deviation happening, I felt like, oh, we've got to start paying more attention here. So the first thing I did was to add lateral trunk supports to his wheelchair. And sadly, that obviously, as you can see here, did not take care of the problem. I've given you two different images here. And the lateral trunk supports that we were able to provide for him, if they were not to interfere with his self-propulsion, were not enough to correct his deviation. And then I looked at him in his lying posture. Okay, and you can see that his lying posture is also deviating in the same direction, and I believe was feeding into his seating. So I provided education and support for night positioning to his mother, and we got him into a standing frame as well. I don't have any pictures of him in his night positioning, but Hammy is going to demonstrate for us what it was that we did. So basically, bringing his legs to a more midline oriented position from abduction, lifting them and supporting them beneath so that his tight psoas could be released. And what you can't really see here, but what we used were actually lateral trunk supports as well that would be on either side of Hammy's spine, and then bringing his spine into that central alignment as well. And then you can also see him here in his standing frame. Here's another lying support example with Dominic. You met Dominic earlier and you've seen his asymmetrical posture, but now you can see how he began to sleep at night. This was at a home visit I did with him. And simply by putting some fairly simple supports beneath the fitted sheet of his bed and giving him some adequate but soft support beneath his knees, we were able to bring him into symmetry and midline orientation so that no longer were his legs falling to one side or the other because of tight hamstrings. So the seating assessment results for Xavier were that he was persistently leaning to his right. Luckily, his pelvis was level. He had an anterior postural tendency, and we know that with people with spina bifida, as well as some other diagnoses like muscular dystrophy, we know that some of those anterior postural tendencies are going to tend to increase in time. His posture was flexible, and he tolerated correction past midline, so that was really good news. And we had tried off-the-shelf supports, and we had found that they didn't do the job. So the strategy with him was that we needed to encourage midline orientation, promote a posterior postural tendency, assist him to do that so that he wouldn't tend to continue to become more and more and more anterior. And we needed to do nothing to inhibit his activity. So our seating strategy, which I'm going to now show you with Hammy, was we started with his anterior pelvis and trunk leaning. We corrected his pelvis to neutral or a little bit posterior. We carefully applied a 4-point belt with some control at his ASIS to stabilize him into very slight posterior pelvis. And we captured lateral supports for his trunk. So here is Hammy just sitting there with his tight psoas and his anterior pelvis. And here in the second image, you can see what we were trying to achieve of trying to control that anterior pelvis just a little bit. Here he is in the seating simulator. We were able to achieve symmetrical midline trunk orientation, slight posterior orientation of his pelvis. We ended up using a 4-point pelvic belt to anchor his pelvis, and applied it very carefully so it could have an influence on his ASIS, but used a 4-point so that it would not be riding up over his abdomen. And here you can see the before and after. Okay, the posture, we basically did our best to control his posture when and where it mattered. We didn't take away any of his full range of movement for activity. And we encouraged a posterior resting orientation so that when he wasn't actively moving, he wasn't actively doing school stuff, he could actually rest backwards a little bit and have gravity helping him to rest back instead of tending to fall forward on his upper legs. So just briefly, what are some of the perceived roadblocks for custom seating and kids? I mean, first of all, I hope I've been able to show you that we can go about this in a way that will provide us with a strategy for funding. You know, if we do a solid evaluation, if we trial the more basic, less expensive products, show that we can make improvement through simulation, we can then justify funding for custom seating for kids. We need to be sure that there is growth adjustment. Ride custom seating happens to be the product that was used in this case study. And we are able to make growth adjustments. We can use growth kits for the seat cushions. We can expand the trunk, the laterals and the back cushion when needed for growth. We may be able to adjust seating for comfort and function while waiting for new. I think that there are some other products that may be out there that will allow us to do that as well. But ride custom seating is what I've been having success with. And finally, really family acceptance. We need to take the time to provide education. I think it can be daunting for families to look at something that is custom and think, oh my gosh, is this really what my kid needs? You know, we all have our dreams and our images and hoping that everything is going to turn out okay and our child is not going to need something that is more involved. Excuse me. But I have found that talking with people about early intervention and trying to address problems early and prevent them from developing into something worse can really pay dividends in enabling people to be able to buy into a more involved, seemingly more involved seating intervention, which in the end is going to be much better for their child. And I would say the same thing for adults with a new diagnosis, a new injury, a new condition of some sort that is requiring seating interventions. So what are we waiting for? If we're going to look at early versus late intervention, late is always too late, as my friend Tom Hetzel says. And health and quality of life are really what's at stake. We have an opportunity to really make a big difference in people's lives through our choices to do carefully targeted postural support, not only in the seating system, not only in the wheelchair, as I've shown you, but also when people are out of their wheelchair and especially at night. And I'm just encouraging all of you to go ahead and do it. And I'm always open for questions. We may have a couple minutes left for questions.
All right, you should be able to unmute yourself if you have any questions. I will throw the CEU code in the chat. It is TJ08K5. That is TJ08K5. And Tamara, we had some great conversation in the chat about non-commercial or commercial and inexpensive types of support that you recommend to families to use for bed and supine positioning versus ordering through insurance. So a lot of great information in there.
Great. I'm so glad somebody asked that question. I am going to refer you directly to the website for my nonprofit organization, Posture 24/7. That's www.posture24-7.org. If you go to the resources page, and then under that is learning materials, both on the resources page and the learning materials, you're going to find lots of interesting information. I was fortunate enough to have an OT doctoral student working with me last summer for her doctoral capstone project. She did a wonderful series of 7 PDF documents and also 4 instructional videos, professional quality instructional videos that actually demonstrate how to make effective supports using household materials, using inexpensive materials. And I can honestly tell you that almost all of the success that I've had in positioning people while they sleep at night has been through use of these informal materials, because I don't know anybody who can afford the really expensive sleep systems. I live in a less resource state in Montana, and there's just no funding. So that's the best source that I know of, all in one place. And I'm so grateful to Madison Mulvaney, who did all of this work last summer and came up with these materials. Any other questions?
Tamara. Hi, it's Lauren Rosen.
Hi, Lauren.
Hey, a question with these kids that you're starting to put into the molded seating systems earlier. Have you been seeing them long enough to see if that actually is affecting curve progression? Because the research that I've seen says you can put neuromuscular scoliosis kids in a TLSO 24 hours a day and it doesn't prevent progression. So I'm just, as I look to payer sources to get low profile custom molded seating, I have a hard time justifying it. I'm just wondering what you're.
Yeah, that's a really good question. First of all, I would say that for me, for myself and my practice, I don't use only that. I'm always coupling it with nighttime postural care. And my experience has been that it's impossible to get a TLSO that is going to provide enough correction to stop rotation within it and still allow the person to breathe, at least where I am. And so I actually have worked with kids who were not wearing their TLSOs at night very much anyway, because they couldn't sleep. And so they'd end up getting out of them at night or having them taken off. We've been able to achieve a better correction with them with the materials that I was just talking about that are on the website. We could achieve a better correction with them while they were sleeping at night. Then during the day, they were in their TLSO, in their seating system, or in custom seating. And so you're really looking at something where you're addressing it all the time, but you're able to get a better correction out of the TLSO than in. I actually have a manuscript that I'm hoping to submit for publication in within the next few months. A case report I have data over 6 years with a young lady that I worked with from age 11, and the last measurement I took of her was at age 18. And we were able to actually improve her body shape using this kind of intervention. Does that help?
Yeah, that's it sounds to me like, we need to finally get all of us on top of the nighttime positioning, as well as the daytime positioning. I think that, that what we're seeing coming out of all of the research across the world right now is that if you're not doing the nighttime positioning, the daytime positioning, while possibly helpful, is not effective in preventing the things that we see in our kids. So I think
exactly.
It just emphasizes that nighttime
It's a
Position.
wraparound. I mean, that's how I see it. It's a wraparound. And I guess, just speaking only for myself, I have kind of become constitutionally unable to assess somebody and not look at this as well, because I feel like if I do, I'm not doing my job. Now, does that mean I can always get people to buy in? No. There has to be a certain amount of buy-in, which was actually one of the reasons why my student last summer created materials that are not only clinician friendly, but also family and caregiver friendly. So especially, I work with adults in group homes now as well. And, I've sent group home managers to watch videos and to read some of these materials during the pandemic when I wasn't allowed in to do any training. And they have been able to learn, and with help from me through telehealth, been able to start implementing some bedtime or in the bed positioning strategies. Because what we need to realize is, somebody like Xavier, he was in his wheelchair like 12 hours a day, probably, right? I mean, he's always on the go and he was never going to be still. But there are a whole lot of people who come home from school or from their day program or whatever. And the first thing that happens is people think they're doing something nice and they get them out and they lounge around on the sofa or the recliner or the floor, whatever it is, without realization that these may be destructive postures that are going to harm them in the long run. So it's a wraparound. Any other questions? Feel free to email me as well with any questions. I'm always happy to answer emails. Oh, I'm looking here at the chat.
Oh,
The
hi.
graphics in the handout are unable to open. I'll have to take a look. Something must have happened there.
I have a question.
Yes.
Can you tell me, do you get a lot of compliance with use of the 24/7 positioning in bed? With it, like something like the symmetric sleep?
Do I get compliance?
Yes, from the family?
Well, I have to tell you that I've only had a handful of people who have a symmetric sleep because as I've said, typically there's no funding for it where I live.
Right.
But whether it's with that or with other supports, I think that the education is really key. I spend a lot of time on that. I'm not afraid to show people, I have quite a few educational resources, and I'm not afraid to show people what might happen, not because I'm trying to be mean, but I find that many people just haven't even been able to imagine what might happen if you're talking about children.
Right.
I also start very incrementally. That's part of what, like when I do teachings and trainings, that's part of what I talk about as well. Sometimes you may need to start off with the person just being in their position of comfort that they're used to, and just let them get used to having a few supports around them in that position that is not new. And of course, you're never going to take anybody to their end range and really be
Right.
trying to stretch them in bed. That's the last thing that we're going to want to do, right? We want to make them so comfortable that they're going to sleep really well and sleep really deep, because that's when muscle tone relaxes. And that's when we can start to make changes, when there's no activity demands at night and when muscle tone relaxes in the deeper stages of sleep. So to do that, you've got to make people really comfortable. And I often talk about it that way with people and with kids. I'll say, we are going to make you so comfy. We're going to put some new things in your bed. We're going to make it so comfy for you. And I pay a lot of attention to feedback. And if I can't read the person's feedback, I'm listening very carefully to the caregiver or the family members, you know, moving something a little bit here, a little bit there, a little bit more, a little bit less. When I used to be able, before the pandemic, when I used to be able to teach in-person courses, we always had a really significant lab portion where people had a chance to experience this for themselves, clinicians, and feel what it was like and find out what worked for them, for their bodies. So I think that the combination of very careful feedback and education, and then incremental changes, just getting used to having something there. And then you can make tiny, tiny, tiny little changes over time once a person is used to it. Does that help?
Yeah, I was just looking for whether you have had success with the families participating with it, or whether you've gotten any pushback.
You
But
know,
no, that does help. Thank you very much.
yeah, it's not published yet. That's another one of my projects this spring. But I did a pilot study, a 3-year pilot study called the Montana Postural Care Project. And we've got data from that showed the levels of participation and follow through. In particular, one year really struck me. Our second year, we only worked with children ages 16 and under. We didn't work with any adults. We did have adults in the other years. And on that second year, 16 and under kids, after 6 weeks, out of 20 participants, we had 16 who were sleeping through the night and doing well in their sleep systems. I thought that was a pretty good percentage.
Yeah, that's great. Thank you very much.
Mhm.
Thank you. I'm going to go to your website. That's interesting. Thanks.
Yeah, and I'll go there and see if there's a reason why the images aren't opening.
Okay, thank you.
Let me know if they don't work. People should email me if they don't work.
All right, we are a little over on time. If anyone would like to jump to the next session or the exhibitor hall, or stay on and answer more questions, up to Tamara. We do have one question in the chat. What about the kids with extreme dystonia and constant movements, where they can overpower pretty much everything and make it even deeper?
I'm looking at the chat now too. Extreme dystonia. What I would say about dystonia, and I have worked with a couple of people with dystonia, kids with dystonia. First of all, fortunately, I think that kids who are dystonic are at less risk for some of the kinds of postural distortions, body shape distortions that we see, because they are moving so much, and hopefully they're moving in a variety of different ways. I think that you do need to be aware of shearing injuries. A lot of that can be rectified through choice of bedding, through how close you have the positioning supports. I've worked with a couple of people with dystonia, and what we actually found worked best for them was that the tendency was to roll over on the side and sleep in a fetal position. And sleeping in a fetal position is pretty much going to be guaranteed to cause some flattening, side to side flattening and deepening of your chest. And so we want to discourage the side fetal position sleeping. And we found that just by building up some boundaries on either side of the person, not real close fitting, but enough that it was kind of a boundary to discourage side sleeping, it was enough to make a difference for that person. And that person also was able to tolerate it. Oh, and here's some messages that the images are working. So great. I'm glad to know.
Is there somewhere to purchase Hammy or something similar that we could use for education? Because I think that would be really helpful.
Yes.
Like when you try to lay on the mat and demonstrate to the parents, they can't really see the alignment entirely.
I'm putting it in the chat right now.
Awesome, thank you.
Meethammy.com. Oh, and somebody wants me to post the link to the materials. Okay, are we about done?
If anyone has any more questions, there's Tamara's email right there, and I'll throw the code in just one more time in case anyone missed it in the chat. And see you all in the coming sessions.